Next speaker to the podium, Dr. Paula Ferrada hails from Cali, Colombia, and afterwards she did her surgical internship at Jackson Memorial Hospital and her surgical residency at Beth Israel Deaconess Hospital in Boston, Massachusetts. Afterwards, she completed a fellowship in trauma critical care at the University of Pittsburgh and then followed up with acute care surgery fellowship at the R. Adams Coley Shock Trauma Center at the University of Maryland. Paula is currently associate professor at VCU in Richmond, Virginia, and I've known Paula for many years, and I have to say that she is extremely passionate in what she does. She's a well-respected researcher, educator, she's a social media guru, and it's a distinct honor to have her here on the panel. She'll be talking about surgical management of C. difficile. Paula?
For such a generous introduction. In the next few minutes, I'm going to talk to you about the surgical treatment for severe and severe complicated Clostridium Difficile associated disease. I have nothing to disclose pertaining to this particular talk, but I do have something to disclose. Why am I talking about C. diff colitis in a trauma conference? The reason is because we, the trauma surgeons, are the ones that deal with any type of surgical disasters. And that is true for most of the Americas and from some parts in Europe. And we are the ones, at least in the Americas, that not only take care of them surgically, whatever disaster it is, if it's active bleeding or a piece of bowel dying or C. diff colitis, but we also take care of them sometimes in the ICU. So that is the reason why we're going to talk about these patients. They're sick and they deserve our attention. Let's start with a case. This is a real life case. 67-year-old male that was receiving antibiotics because he had a pneumonia, developed diarrhea 3 days before presentation. In the last 12 hours, then he stops having urine output and he's in the emergency room for evaluation. Medicine served admit him for hydration. Surgeries is still not involved. This is important to pay attention. He has polycystic kidney disease, he's hypertensive, he had bilateral nephrectomies and a renal transplant, and because of the immunosuppression develops some kind of skin cancer that he had surgery for. Some family history of atherosclerosis, he doesn't smoke or does drugs, but he does take narcotics chronically, he does take famotidine, and now he's taking levofloxacin for the presumptive infection, and he's on prednisone, and all of these are issues that are going to become important later on. When he presents to the emergency room, his white blood cell count is 35. His creatinine is 2.5 from a normal of 0.8. He's clearly dehydrated and he's admitted to the medicine service. He's hypertensive, but now on the day of admission, his blood pressure is soft. He's a little tachycardic. Abdomen is distended. He has diarrhea. They're just hydrating him. In hospital day number 2, the diarrhea stops. Is that a bad sign or a good sign? Bad sign, right? Blood pressure is still soft, a little bit more tachycardic. He spikes a fever. Now his abdomen is distended and tender, but non-peritoneal. So this is, they get a KUB, and this is the KUB that it shows. At this point, they sense C. diff, but it's not back. The medicine service then decides to take him to a CT scanner to investigate reasons of sepsis. So the patient gets to a CT scanner, and as they transfer him from the stretcher to the bed, he deteriorates. He starts desadding. He starts becoming more hypertensive. They stop the CT scan wisely at the time. They start him on antibiotics IV for his potential septic shock. They give him stress dose steroids because they think that he's having an additional crisis, and then they call surgery about 8 hours after he deteriorates. We see him as a surgical team. We post him urgently, and we start Flagyl IV on the way, but we're going to talk more about what happens next and what we need to be in tune to these patients. So the incidence of C. diff continues to increase. And if in your hospital or in your country you tell me, oh, C. diff does not exist, for example, in Chile, it's perhaps because you're not measuring it. This continues to increase, and the bug continues to be more and more resistant to our therapy. And why is this important? Because people are dying from this disease. And as you get a little bit older, your chances of dying from this is higher. This is worse when it's severe or when it's severe complicated. For you to have severe associated C. diff infection, you don't have to be that sick. If you have a C. diff infection with a Y count of 15, that's already complicated. If your renal functions is not that great, and you don't have to have an increased creatinine for people that don't have that much muscle, decreased urine output, that's already severe. Severe complicated is when you're hypotensive, have shock, and you have megacolon. Usually, these people that are severe complicated do not present with diarrhea. That is, they're too late and the bowel is not moving, so they're going to be actually having an ileus. The mortality in this case is about 80%, even when we do surgery to save their lives. And then why surgery is called so late? So they have done an amazing job in educating the family physicians and the internists about how we have to be attentive to these people with diarrhea, send the C. diff, especially if they have antibiotics, especially if they're having narcotics, especially if they're in a PPI. But this is a beautiful review from JAMA. If you haven't read it, it's wonderful. The problem is they have surgery right there, in the little tiny corner, basically as our last ditch resource. If your patient is dying, that will be the time to call a surgeon. Probably too late. Probably too late to do a warm autopsy at the time. So we wrote this guideline. This was a few years ago, I want to say. We published maybe 2014. We went back and we did a systematic review, and also in using the GRADE methodology, wrote a guideline. We asked 2 questions. In patients with Clostridium difficile, does early surgery versus late surgery decreases mortality? And in patients with C. diff associated disease, does total colectomy versus other procedures decrease mortality? We found a lot of articles and a lot of things that we were really surprised that in the last 10 years actually got published. Honestly, we removed everything that was not a prospective, and that was not that was a review, and we removed the pediatric population. We were left with only 8 articles to talk about the question number 1 and 17 question number 2. When we examine early versus late surgery, and we mean early by before you go into vasopressors, or if you are in vasopressors, you start maximum medical treatment, which is high-dose vancomycin per mouth and per rectum plus the flagell. You do that for 3 days before you make the decision. You don't let the patients linger. Early surgery is that, then patients do better, and they have a decrease in mortality. Now, what type of surgery? And this was the surprising thing when we looked at the literature, what people did for C. diff. So let's say you open the abdomen, this patient that I told you about. You open and you see a boggy colon but no necrosis. Who here will not take the colon out? Good. Who here will take the colon out? Everybody. Who here will do a loop ileostomy and washout? We'll talk about it in a second. How about number 2? And then I know that the answer is going to be here because it looks like everybody here is very well educated on this. Anybody here will not take the entire colon when you see just a piece of bowel injected locally or necrotic. Great. Because C. diff is a disease that happens in the mucosa, and you're toxic because the mucosa is completely infected. The people in our review that opened the belly, saw a boggy colon, didn't do anything, close and back, negative X-lab, and had to retake it, had the opportunity of taking that patient again, and then removing the colon, those patients had 100% mortality. The people that had a piece of the colon removed and not the entire colon out, super high mortality. Now, at the time that we wrote the guideline, VCU was one of the centers that participated in an attempt of doing a randomized control trial talking about the loop ileostomy, the Pittsburgh protocol, but we had to cancel that because we didn't have enough recruitment. So we could not comment in this guideline about that protocol. For those of you that don't know what it is in patients that you can do it laparoscopically, you do it laparoscopically, not, you do it open. You bring a loop ileostomy, you wash the feces out, we go lightly, and when it's clean, you place a tube and you inject vancomycin at high dose. That's 500 milligrams in 500 cc's, so you have enough that reach the colon. And why this topical therapy works is because you have an ileus, as I mentioned before, when you're very sick from C. diff. So even if you do per rectum and per mouth, the vancomycin needs to reach that mucosa that is diseased. And Brian Zuckerbrand wrote this and found that they had a decreased mortality. They compared with historical controls. It was not a randomized controlled trial, but the mortality decreased in their hands from 15% to 19%, which is significant. So then we thought there was a need to compare both. Why? Because some of us that were early adopters found that was not as clear-cut as the loop ileostomy is going to be amazing. A couple of patients, there's nothing like introducing a new procedure to your group and then having that patient fail and having to do a total colectomy, or having that patient fail and die. So we presented this in EASE, and we just published it in a Journal of Trauma in July. We looked at these patients retrospectively because we knew that there was not enough patients to do it prospectively, as we had already tried, and we compared the two procedures. We compared from July 1st to July 30th, July 1st of 2010 to July 30th of 2014. We removed the patients that died on the way to the OR. These patients were still sick. Mortality was 32%, overall complications 75%, and they were a little older. The majority were on pressors, 47% were in renal failure, and 36% had respiratory failure, which are the markers of patients' disease in all the papers that we read and in real life when we're treating our patients. There was no differences between complications, planned or unplanned takes back to the OR. There was no difference in length of stay or ventilator days. The only difference that we found was in the estimated blood loss, obviously, because the total colectomy can take you a little bit more time than creating a loop ileostomy. And we found, as Dr. Holcomb mentioned before, we did find the evil crystalloids. There was the patient that had the total colectomy had more. Although we cannot blame everything in crystalloids. And the mortality was worse for people that have total colectomy. We think that in patients without contraindications, and I say still this, I don't think that we can recommend this strongly. I think in patients that do not have any distal obstructions from diverticulitis or anything like that, we can consider loop ileostomy. We still have to see what happens after you get them out of shock and decide to reanastomose them, if these patients recur, and how. Our patient had a total colectomy. He was off pressors in 24 hours, went to rehab in 7 days, and recovered his renal function fully. He has not presented with that recurrence because he has his colon out. I'm not reversing him. I talked to him a couple of times about it. I think the only way that we're going to be able to prevent death from these patients is to increase awareness and have a high suspicion. We need to have early aggressive medical treatment, and it's impressive how many people do not know what that is. When a patient is that sick from C. diff, you need high-dose vancomycin per mouth and per rectum, and the flagell. That's 500 milligrams of vancomycin per mouth and per rectum. Early surgical consultation and working together, and early surgical intervention before it's too late. The loop ileostomy could be indicated if there's no ischemia, if there's no distal obstruction, if there's not abdominal compartment syndrome. All of them are obvious. The one that I cannot explain is the anuric renal failure. I have compared notes with our friends in Pittsburgh, and our clinical experience is very similar. People that are already in anuric renal failure do worse and have higher chances of failing loop ileostomy. So total colectomy still has a role. We need protocols for care. The way that at least at VCU we decreased the mortality of these people was by working together with the medicine people. We work as a team together very well. We involve the infectious disease colleagues. If you're going to have 2 more consults or 10 more consults for people that you're not going to take to the operating room, it's worth it if that's going to result in saving one life. And continue to work together as a rescue resuscitation and rescue surgery, which is our roles as acute care surgeons and trauma surgeons in the entire world. One of our major roles continues to be rescue surgery. Thank you for your time. If anybody has questions that we cannot cover, this is my email. I'll be happy to work with any of you in future projects.
Thank you, Paula.